Good morning and welcome to the ARC Michigan Disability Policy Webinar Series. I'd like to go over a few housekeeping items before we get started. If you look in the upper right-hand corner of your screen, you should see an orange arrow, and this is your go-to webinar control panel. If you've joined us today via the app on your phone, the control panel is in a pull-down menu at the top or bottom of your screen. If you have any issues with your audio, you're going to want to go into your GoToWebinar control panel and do the mic and speaker sound check. Participants are muted for this presentation, but you can type your questions or comments into the GoToWebinar question window that's in the control panel. When you're in the control panel, there's also a tab that says Handouts, and that's where you can find a copy of today's presentation. If you lose your GoToWebinar screen at any point, you're going to want to look for the blue flower icon in your taskbar to bring it back to the front screen on your computer. Good morning to Sherry Boyd.
Good morning, everyone. I want to welcome you to the third of 4 weeks of public policy information. This week we have Belinda Hawks from the Behavioral Health and Developmental Disabilities Administration. She is currently the director of the Quality Management and Planning Division, and she has served over 30 years in our field, working as a provider of residential services, an administrator of community mental health services, and then was the manager of the federal compliance of Medicaid behavioral health specialty services. That was probably her last job at the Buddha. I'm happy to have Belinda here. I always refer to her that we grew up together at Livingston CMH many years ago, many more than I want to admit. But we're happy to have her here, and thank you, Belinda, for coming.
Thank you, Sherry.
Welcome.
It's good to be here, and I'm always excited to be invited to participate in this annual event, and hope that the information we provide today is useful and valuable as you move forward in the work that you do and in the supports that you provide. And so Sherry indicated, I'm the director of behavioral health, developmental disabilities services under quality management and planning. And within my division, we oversee the work of federal compliance, which would be where the waivers live, the children's waiver, the SED waiver, and the habilitation supports waiver. It is also where the 1915I will live when it becomes unofficially an I. It's currently under an 1115. We also oversee the ABA benefit under the state plan within federal compliance, and conduct all the site review, quality reviews related to those waivers on that team. This team also has the responsibility of the home and community-based services rule implementation, which is underway at this time. Within my division as well, we oversee the OBRA services for those that are eligible or considered eligible for nursing home placement. And we also have within the division community practices and innovations, which is really focused on evidence-based practice for adults with SMI. So again, thank you for your time today, and we can move to the next slide. So today we're going to cover a few topics that have been covered in past webinars, but also some new topics as well. We're going to get you an update on the waiver and state plan status related to the COVID-19 flexibilities. We're going to talk about telehealth and the options that are still afforded to us related to COVID and post-COVID. The stability plans, again, as we are working with the PIHP, CMHP system to make sure that they have a stable provider network. And then we're going to give you a couple of updates on the home and community-based services rule and conflict-free case management. I also wanted to let folks know that feel free to put questions in the chat throughout the presentation. I'll be pausing and checking in to see if there are any questions in the chat, and then we'll be also offering an opportunity at the end of the entire presentation once I present and the next presenter is completed with her presentation as well. So next slide. So this will look familiar to everyone because this was really a slide from last year's presentation related to the various COVID-19 Medicaid authority flexibilities or options that were allowed to us by CMS, both on the 1135 waiver, which is really the broad Medicaid state plan waiver, the 1115 waiver, which is more specifically the behavioral health waiver where the 1915I is currently living, and then the Appendix K waiver flexibility, which covers our 1915C waivers. Next slide. So this again is a repeat in that it's just a reminder of what flexibilities we were allowed to have under the various waivers and state plan amendments. So again, allowing for flexibilities around prior authorizations, permitting services to be approved, to be continued to be approved without a need for a prior auth, temporarily and provisionally enrolling and reimbursing new or out-of-state providers who meet the specific Medicaid and CMS criteria. Alternative setting reimbursement, again, some of the funding prior to COVID was tied to certain settings that were defined as home and community-based, but this allowed some flexibility for where the services could be rendered. It, of course, allowed states to do telehealth and telephonic expansion, and then some flexibility in the planning process, which just again has to do with the timing of when a plan might be due to be reviewed or renewed, and allowing some flexibility around that timeline. Next slide. The 1115 is again another way that the state was able to leverage some flexibility. Again, some overlap in those flexibilities related to all three around person-centered planning, again allowing for telehealth, reassessment timelines that were flexible, level of care and reevaluations the same, payments again for alternative settings, payments to certain habilitation and personal care providers to maintain capacity. That really had to do with stability, and looking at quality measures that could be, again, reviewed differently related to timelines of when they might be due to be reviewed, which would be a part of our site review process, except for health and welfare assurances. Next slide. And then the K, which is again specific to the C waivers listed here, allowed for some of those same flexibilities. The provider qualification one was unique. It again made sure that we continue to look for universal precautions because of the need to make sure staff were following those, especially during a pandemic. Competencies for task were needed and necessary, and that they needed to effectively communicate and be able to understand the plan of service. But other qualifications could have been relaxed somewhat. Particularly, we saw those related to staff needing to renew first aid and CPR type of expired trainings, that those could be flexible and expanded somewhat because there might not have been access to those renewed trainings during the pandemic. And then really increasing payment rates, which was a part of what we call the direct care wage increase or the premium pay. and allowing for payment of services to support individuals who are on these waivers that may have been hospitalized due to their COVID status. Next slide. So I wanted you guys to be tracking on these because they're still in play. Those flexibilities will continue to be in play as long as there is a public health emergency, which at this point is now through July 19th of 2021. However, we also know that there is some conversation at the federal level happening indicating that there is a possibility that PHE or public health emergency may be extended another 90 days. That's the most those extensions can occur is within 90-day increments. So we have heard there is some talk about extending that public health emergency again. And that's important to track on related to these flexibilities because of the nature of how they're tied to this public health emergency. Next slide. So again, this is important to note that each authority had a different termination date based on the public health emergency. The 1135, which is the Medicaid and the CHIP 1135 waiver, was effective March 10th and will expire at the end of the PHE. So whatever date that is, those flexibilities would also expire. The Appendix K is no later than 6 months after the PHE. So you would have the opportunity to take out your flexibilities 6 months beyond currently the July 19th public health emergency timeframe. And the 1115, which is 60 days after the end of the PHE. And I wanted you to note at the bottom of this slide that we're noting that there is some flexibility around Medicaid eligibility currently in play, as well as that when these public health emergency timelines are terminated, that there will be an expectation that PIHPs will need to comply with the relevant regulatory provisions, transitioning back to regular operations at that time. Next slide. So again, this is just talking about the way that we would be looking at the planning process for moving to the normal operational procedures or changes. And then looking at particularly any backlogged pended items that were allowed to be pended during the PHE or the flexible authority allowed. And then again for the waivers, particularly the C waivers, that 6-month restoration of what we would want to see occurring related to those routine expectations. So this is an important one because Medicaid is beginning to look at what they would need to see in the way of a process to begin to look at redeterminations of Medicaid enrollees. And I understand that that is being looked at now with a possible timeline of January before there would be action taken if the public health emergency does not get renewed again. Next slide. Related to the 1915I, again, that is a new authority that we pursued because we were not able to renew the B waiver, which is where most of the services, behavioral health services, lived outside of the 1915C waiver authority. And we moved to pursue and receive approval for 1915I, understanding though that the need for the state to conduct annual eligibility and re-eligibility reviews for a very large number of the population served in that former B waiver was we needed to build the infrastructure for it. So what we did was asked that the I live under an 1115 authority and gave us the time we needed to develop the infrastructure to implement the certification and recertification of the enrollees for that benefit. So the original approval was for October 1 of 2022. This again was prior to the pandemic. So we have asked in a call with CMS to extend that implementation date of the I to October of 2023. CMS has indicated this, they are in support of the state pursuing that option and have asked that we look at opening up the 1115 to amend that application to include this extension, which will require public comment period. So we're building that amendment information in the 1115 now with a plan to begin the work of drafting and public comment in the fall. And the waiver support application is the structure or the platform that we're using to do the state level reviews. And that is under the redesign of that platform is underway as we speak. Next slide. So before I move on to telehealth, I want to just stop and check in. Are there any questions in the chat?
There are no questions at this time, Belinda.
Okay, thank you. So telehealth was one of the flexibilities that we leveraged in all three authorities that I covered earlier in the presentation. And I wanted to just check in with you related to some data that we were able to pull that just reflects the flexibility and how it was used across the behavioral health system. So we're going to look at really some ways that we were able to show how that flexibility was leveraged in the last year and a half. Next slide. So sorry for the small font. There's a lot of data here. I'm hoping that folks can zoom in and take a look at your leisure. But this is just an opportunity to really look from January of 2020. So we wanted to give you a sense of pre-COVID baseline data and then post or actually in COVID data as well. So you'll have a timeline of January of 2020 to January of 21, where you're going to see where the telemedicine unique visit encounter numbers were pre-COVID and where they moved and how they shifted up and down, pretty much correlated to when we saw an uptick in case numbers across the state. So you'll see both telemedicine unique visits at the top or down the side, and then you'll look across at the month. And you can see how as you go to the right for telemedicine, we had around 11,000 in January of 2020, and it quickly moved up in March to over 161,000. And in April, 369,000. And then you see a shift down somewhat in the summer months, and then a shift back up in October with a kind of a flat curve related to the winter months in telemedicine. Then there were the in-person visits. We thought it was important for you to know what the face-to-face visits look like during that same time frame. So this, I think, is just important information as you consider how telehealth has impacted service delivery, and will continue to be pursuing a policy around telehealth going forward. Next slide. So again, we wanted to point to the visits by PIHP. So you'll see across the top, the PIHP, it looks like Oakland unfortunately got squished a little bit in the columns. Again, I think it was just the sizing of this particular slide. And down the bottom on the left, you'll see the same months reflected. The member types, we just wanted you to know that we were both looking at the member type 88, which would have been for substance use disorder, and 89, which would have been for mental health or developmental disability encounters. The encounter data was for October through December, may not be complete because there is a time lag for those encounters coming in at times. So I wanted you to understand that, and that the data was extracted January the 27th of 2021. Next slide. So here you're just going to see that same data reflected in the chart. Again, looking at the telemedicine unique visits, which is the blue line, the in-person visits, which is the orange or red line, and then the total visits in gray. This is for, again, the same time frame. Next slide. These are the unique beneficiaries who had both telemedicine and in-person visits during that same time frame. Again, the blue being telemedicine and the in-person being the orange, gray being the total beneficiaries. Next slide. Again, I'm going to stop here with all of that information. Any questions in the chat?
No, not yet.
All right. So this is just some information related to reporting requirements and updates, and where you might be able to find that information through our code chart, our telemedicine database, and then any questions that you might have regarding telemedicine can go to that email address listed in the purple below. Next slide.
Belinda,
Yeah.
I'm sorry, we did have a couple people asking the exact same question. Will the telehealth provision continue?
Right, so the telehealth provision will continue. Whether it continues in its current form, which was allowing for both audio and visual and/or, is still out for discussion and federal guidance. So we do expect to have telehealth continue as an option for services, and that telemedicine database here on this side really points to the post-COVID service code set that will be allowed to be offered via telemedicine.
Thank you.
You're welcome. So these are policies, again, related to the flexibilities that were allowed during COVID, and there's also the proposed telemedicine code or policy listed as well. So again, some of those are in flux. I think as of yesterday, some of the state restrictions related to COVID restrictions have been relaxed or will be relaxed next Tuesday, I think the 22nd. So we'll be taking a look at those policies just to see if there's any changes or amendments we need to make related to what we've written in those particular policies. Next slide. I mentioned stability plans. I'm just going to cover those briefly. We wanted to assure that there was provider stability during COVID. So we did an evaluation. We requested that the PIHPs submit what their plans would be for stabilizing their network. And then we've asked that they submit those progress reports to the state on a monthly basis. So we are conducting ongoing assessment and review the implementation of those stability plans ongoing, and continue to do that to this date. Next slide. So through April, the total reported provider support funding that the PIHPs have authorized through their stability plans since June of 2020 is over 54 million. Again, this does not include the direct care wage increase or the premium pay increase. The total number of providers, again, statewide reported to have received some type of support from the PIHP is 613. There were 16 providers that reportedly closed as a direct result of the pandemic. And that support looked like lump sum payments, general rate increases, again, COVID-specific rate increases when you were shown to be serving those diagnosed with COVID, wage increases, and then cost reimbursement contracts. Next slide. So heightened scrutiny is the stage at which we, for our home and community-based services rule implementation, where we are now. So I wanted you guys to just get a quick update on the fact that the home and community-based service rule is still in play related to a transition plan for all states to be in full compliance by March 17th of 2023. That again was extended out a year due to COVID. And the state Michigan chose to continue the timeline that we initially had in place with the CMS review. So the Heightened Scrutiny Review Committee is the committee that's been established, representative of diverse stakeholders for the department, that helps to review evidence of settings that are provider owned or controlled, providing HCBS services to beneficiaries who, because of their status of heightened scrutiny, need to be reviewed by a committee as to whether they would then move forward to public comment, from public comment to submission to CMS for approval, again with the timeline of April 17th of 2023 for all providers of HCBS services who are provider owned and controlled, identified as in the rule, would need to be in full compliance. So the next slide just shows you sort of that process where the setting is identified, we gather evidence, we do a first level review, and then we are in that second level review where the information is provided to the department, and then the Heightened Scrutiny Review Committee takes a look at that evidence. Who's collecting the review evidence of those settings for the department? It is a contractor with Michigan State University who's collecting the evidence for us, providing it to us, and then that is what is provided in a Heightened Scrutiny Review Committee packet to those committee members. And then once that review is completed, then the packet is reviewed again by the department for then submission for public comment of those settings as to whether they could potentially overcome their heightened scrutiny status by way of the information provided to the committee. So again, that's about where we are now. We are not waiting for all evidence because it's a rolling review process. So as we get evidence from our MSU contractor, we are engaging with the HSRC committee to begin those reviews. And we're going to do the same with the public comment and CMS review as well. And we expect that we'll have the first set of evidence packets for public comment in the next probably 6 months or so. Next slide. So,
Belinda, we did have a couple questions about that last topic, if I can interrupt you.
I'll take it back to that slide maybe.
All right. Where would somebody find more information on the Heightened Scrutiny Review Committee?
There is an HCBS webpage, and there's also an HCBS transition email box, and I think it is HCBS transition@michigan.gov. That when you send in a question or inquiry to that email box, it will come to the HCBS team under federal compliance.
Okay, thank you. Another question, a little clarification. Those stability plans that the PIHPs submitted as a result of that they had the ability to support providers who were struggling due to the pandemic, for example, with overtime payments because of the staff shortage. Is that what this means?
It definitely was an option that PIHPs could leverage, yes.
Okay, thank you. Another question, is full compliance by March or by April?
Oh, did we have two different dates?
I think so.
Uh-oh. It is March 17, 2023.
Thank you.
Thank you. Good catch.
Another question. Has Buddha provided any stability supports to people who don't use providers, instead hiring their own staff through self-determination?
Not that I'm aware of. That would again be a responsibility of the PIHP to engage with those employers for anything that they might need.
Thank you. That was my last question for this slide.
Okay, good questions. Thank you. So conflict-free case management is something that, again, was identified as a topic of interest. So I just wanted folks to, again, understand the context. Conflict-free case management is a requirement both in the home and community-based services rule and in the managed care rule. We understand that there's been some start and stops related to work around designing a policy and the contract requirements around conflict-free case management. So we've re-engaged with a contractor, TBD Solutions, to get the department some information and begin that work anew. So we began that process with TBD presenting at a recent PIHP Directors Forum. Also, the Quality Improvement Council meeting. There is a survey underway to the CMHPs that the next presenter will talk a little bit more about. And then we hope to collect all of the information gathered in those various forums and bring it back through the Quality Improvement Council work in the fall of 2021. So it's my pleasure to introduce the representative from TBD today. Again, that's my contact information if you do have any questions from me. But I'd like to introduce Remi Romanowski Pfeiffer. Remi?
Thank you, Belinda, so much for the introduction and kicking us off with the context there. So as Belinda mentioned, you know, a lot of this conflict-free case management is under the umbrella of the HCBS final rule and the managed care rule. And so today we're going to dig into our work in the conflict-free case management realm. And so really our main questions here, we were invited to look at how do states approach conflict-free case management in their waivers, and really understand the current landscape of waivers across the country. So getting to know those waivers and how states are addressing conflict-free case management within the waivers. And then lastly, we really wanted to dig into the current implementation practices in Michigan. So this is the survey that Belinda mentioned and that we'll dig in a bit today as well. So we can move on to the next slide. Like I said, Belinda gave some great context there, and I'll just, before we jump in, I'll provide a couple of other details as well to kind of set the stage here before we dig into the analysis. So on the next slide, we're going to start with really just looking at definition of case management according to policy. So really the policy defines case management as these 4 key activities here. So assessment being one of those, and then individual plan of service development, so really developing that IPOS. And then also implementing and monitoring the IPOS is another one of those key activities. And then lastly, the referral piece is the 4th key component here as defined in policy. So this is kind of the general context of conflict-free case management as we'll be speaking about today. But today's focus will really be on those 2 blue middle rectangles there with the IPOS development and the implementation and monitoring. So that will be our key focus today. Also, as we dig in, you'll notice that a lot of the focus is on the 1915C waivers. So there's a lot of detail in those waivers about how to mitigate risk. So that's really where we started our analysis, was using that 1915C waiver. And so within those C waivers, there are 2 components that we'll talk about today, including firewalls and safeguards. So I'll dig into those in a minute, but I just wanted to provide you with this context of when we're talking about case management today, we're really talking about these 4 key activities, but more specifically, those 2 blue icons in the middle of IPOS development and then implementation and monitoring. So we can move on to the next slide where we'll start to dig into these firewalls and safeguards that I mentioned. So really a firewall is, what we're calling a firewall is the structural mitigation approach. So this is a protection against conflict that is very much structural, it's well defined, and it creates a difference in financial interest between what we're labeling here as Organization A and Organization B. And you'll see here that Organization A is providing those IPOS activities, right? The IPOS development, and then the implementation and monitoring. And then Organization B is providing those direct service delivery, so those direct HCBS services. So firewall creates a very structured difference in financial interest between Organization A and Organization B here. So we can move on to the next slide where we'll talk about the other mitigation approach, which is a safeguard. And this is more of a procedural mitigation strategy that protects against conflict. So these are protections that amplify the voices of those served, and we'll start to talk about those specifically later in today's presentation. But these can be implemented really across the board from IPOS development all the way through the direct service delivery within the same organization. So, some of these would include self-directed arrangements or supports brokers or independent facilitation. And these are another tool that states can use to mitigate against conflict. So again, these are more procedural, but they can be used, firewalls and safeguards can be used in some kind of combination with each other. And states can select how they want to combine these different mitigation approaches within their waivers. So we can move on to the next slide, but I want to pause here because that is really us kind of setting the stage before we dig into our analysis. So if you have any questions, feel free to throw them in the chat. If there are any, I can take a second to answer those as well.
We do have some questions, but they don't relate to what you just covered, and they might be questions for Belinda, so I'll hold them till the end of your presentation.
Thank you so much. Thanks for adding your questions in the chat. Okay, so that's kind of the context of when we're talking about case management, and then when we're talking about firewalls and safeguards. Really wanted to set the stage there with what the specifics were on that. So next we're going to start to dig into our analysis, and we started by looking at the waiver approach. So we wanted to know, how does Michigan and other states approach their firewalls and their safeguards within their waivers? So this was the first step in our analysis. So you can head on to the next slide there. And what we found was that Michigan does not often indicate the use of structural firewalls within its 1915C waivers. So on the left-hand side there, you'll see the list of the waivers, the 1915C waivers, and then along the top you'll see names of specific firewalls. And you can see there the MI Health Link, or the Duals project, is one of the waivers that indicates the use of a structural firewall. And so this is just helping us understand, how does Michigan approach waivers? And then we'll start to zoom out to other parts of the country. But first, we can move into the next slide where I'll talk about Michigan safeguards. So on the last slide, you saw that one firewall dot indicating that there was, firewalls indicated in that specific waiver. You can see on the other hand, all of Michigan's 1915C waivers indicate a number of safeguards, and really quite a variety of safeguards in all of the waivers, with obviously a number of dots within each waiver. So again, in this chart, along the left-hand side are the names of the waivers, and then along the top are the names of the different safeguards that are indicated in the waivers. So Michigan's waivers indicate the use of many safeguards in a variety of different safeguards in each of their waivers. We can move on to the next slide. So those last two charts were really Michigan up close. This chart here is showing us if we kind of zoomed out to the rest of the country, and you can see Michigan here in the center blue, that almost the tallest blue line right in the center there. And so that kind of shows you Michigan's approach and compares it to the rest of the country. And you can see each color on this chart is representing a different approach to mitigation strategies within waivers. So there's quite a diverse way that states are approaching firewalls and safeguards within their waivers. And so we wanted to kind of show you in context of the rest of the country what Michigan looks like. So this is really comparing 282 of the 1915C waivers across the country. And so just to give you an example, on the far left, Arkansas is a solid green line on the far left. It's the third from the left there. And that one indicates, Arkansas indicates the use of many firewalls. So in those first green charts with the dots, those charts would look almost the exact opposite from Michigan's. So the first chart would have a lot of dots, and the second chart would have not very many dots at all. And so this kind of just helps us see how the different approaches that that states have across the country, in putting Michigan into context there. So there's also an opportunity for states to have different approaches. They might, each of their waivers might have a different approach depending on the waiver, and so that's also captured here as well. So it kind of just gives you an idea of the different ways firewalls and safeguards are indicated in waivers. So we can move on to the next slide and take a pause for any questions here as well.
Thank you. We do have one question on that last set of slides. Is there a conflict with conflict-free case management and behavioral health homes, community behavioral health homes, and other such models where all the services are delivered by the same entity?
Yeah, I wonder if Belinda could jump in and provide her perspective on this question. That's a great question.
Yeah, I do think that would be something we would want to consider as we move policy forward. There are some flexibilities allowed within this federal requirement that would extend to options that are not available, for example, in certain parts of the states, but I don't know that you would leverage those in this example. So I think that would be something we would want to make sure to bring as a part of the conversation going forward.
Thank you for your question. Unless there's any other questions, I can press ahead, kind of moving into our next part of our research. So that last part was really looking at waiver approaches and how states indicate their approach within that waiver application. And so then as we moved into our analysis, we started to ask about how safeguards are implemented or resourced across the CMHs. And so we developed that survey that Belinda mentioned earlier, really in collaboration with the Quality Improvement Council, which has representation from several different organizations. And they helped us and provided us helpful feedback really to hone in on that IPOS resource survey to learn more about how these safeguards are implemented at the CMH level. And so I'm going to walk through each component of the survey here. We can move on to the next slide. So again, we were really looking at how CMHs implemented these safeguards, and specifically these 6 safeguards that we have listed here are ones of focus, including independent facilitation, supports broker, fiscal intermediary. And again, these are examples of safeguards that do mitigate against risk of conflict. So we wanted to learn more about how CMHs were resourcing these. So you can move on to the next slide here. Some of the questions that we're looking to get answers to or we're curious about, there's 3 included on the screen, and so I'll walk through each of those. The first one is really where in the process are safeguards being implemented, or when do the CMHs use safeguards? So specifically, are they brought in during pre-planning? Are they brought in during the person-centered planning meeting? Are safeguards utilized to help develop goals and objectives? We're really curious on where these safeguards are implemented in the process. And then the second question being, where regionally are CMHs reporting using these safeguards? So which CMHs report using these safeguards? And we want to learn more about what parts of the state are comprehensively involving safeguards, and if there are any regional variations or gaps in safeguards there. So that second question is really about regional variations across the state. And then that last question there is, what types of relationships do CMHs have with those providing services? So really, how are CMHs engaging these safeguards? Are they contracting for them? Are they employing them? Are they independently offering them? So these are some examples of questions that we were trying to get at in the IPOS resource survey there. It kind of gives you a high level of what we were looking to get more information about. So we can move on to the next slide. And so as far as next steps, really the first step is to finalize that national research that we talked about in the beginning about where that really colorful chart. We want to finalize that research here in the summer, this summer, and then from there we want to complete that analysis of the Michigan implementation, looking at the data collected from that IPOS resource survey late in the summer, the summer of this year, and then really taking that to complete a gap analysis and action plan, and looking at the desired state, what compliance says, and then also what the current state looks like currently. And so that's kind of the timeline there of next steps of what we'd like to see moving forward. But with that, I will pause for any questions for Belinda and I, and hopefully be able to get your questions answered there.
Thank you. Can you give an example of a firewall approach versus a safeguard approach?
That's a great question. So I think the best, just because this looks differently across the country, I'd hate to ask someone to move back in the first few slides, but an example of this is really in that organization A, as far as a firewall goes, an organization A providing IPOS activities, and then organization B providing direct service delivery. So that would be an example of a firewall, just generally. And then an example of a safeguard, would be the use of independent facilitation is an example of one safeguard, as is supports brokers is another identified safeguard, independent advocates, for example. And so those safeguards can be implemented throughout the process in more of a procedural way. And then the firewalls can be implemented more in a structural way. So I hope that provides a bit more context there.
We have a request that you explained just in a little more detail. What exactly is being safeguarded against with these firewalls?
Yeah, great question. I'd love for Belinda to jump in, but just generally, the protection is around financial interests and protecting people against different conflicts of interest. And so I'll toss it to Belinda, though, if you have anything else to add to that.
Yeah, I think you're right, Remi. It's also, of course, about where the decision-making authority lies for who's assessing the need and who is providing the service.
Thank you for that answer. Next question is about self-determination. Self-determination is a way for people to have control over their lives, and sometimes advocacy is required by an outside organization if the person thinks the system is not meeting their needs. It seems inaccurate for the system to call outside advocacy a safeguard against used by the system. Can you explain that further?
Yeah, Belinda, I'm wondering if you could provide a bit of context there.
So if I'm understanding the question, or a comment, actually, it's appearing that you are wondering why we would term the person in an arrangement supporting self-determination, seeking advocacy or support as a safeguard. Am I understanding that right?
I think so.
And what is the concern related to that?
It seems inaccurate for the system to call outside advocacy a safeguard used by the system.
Okay. So what I'm hearing is that this isn't something we could point to necessarily as a system safeguard, because it's an outside advocacy for that individual. If I'm understanding correctly. So Remi, we can revisit what we point to and how we think about what we would think about in the way of safeguards. Because
Great,
of course, there are system safeguards, and then there are safeguards that are external to the system.
Thank you. We can take a look at that.
All right, oh, go right ahead.
No, I was just going to ask if there were any other questions.
Okay. Yes, there are a few more questions. How is the IDD community represented on the Quality Improvement Council? Are there people with IDD, family members involved?
We will be looking to expand the membership of that council, because it's been historically representative, but I've seen membership sort of waning in relationship to the diversity that I'm looking for on that council. So I am revisiting the membership and a plan to engage with stakeholders around that.
Thank you. The follow-up comment to that was that people with disabilities should have a voice because their actual experience is different than the CMHSP's reports.
Absolutely. Thank you for that.
All right, another question. Oops, pardon me. Does the DHHS have data relative to how many persons receiving CMH services died of COVID?
We do not have that directly. I think there has been an ask to take a look at that. And I would want to check in with our data experts related to that information. I do know we can understand who's received services that were telehealth, again, attached to the COVID flexibilities, but I don't think we have that directly because of the encounter information that we get would not indicate that reason for death. There would be other data sets that we could potentially access, but I would have to talk to our data folks to find out.
Thank you. And we do have your email address within the presentation. So
Yep.
if we don't get to somebody's question, they can definitely follow up with either of you or
Absolutely.
contact us at info@arcmi.org. So hopefully we can fit in a couple more questions before it gets to be 11 o'clock. Will the online trainings for CLS staff that before COVID were required to be in person remain available online as they are now? It's really increased access.
I'm assuming we're talking about trainings that are offered by the CMHs.
Yes, such as rights, Medicaid administration, first aid, and CPR.
I think that's a great idea, and I would support that effort, absolutely.
Thank you. Our PHIP director forums, public meetings where the public can listen to the discussion that's taking place?
They, to my knowledge, they are not public meetings.
Thank you. If a person has a provider who's charging a questionable amount of fees for very minimal service, who could that person contact?
So the provider is under contract with the CMH for those services. And that would be who I would reach out to if you have a question or concern about either the quality or the type of service you're receiving.
Thank you. Our last two questions here. How are people with IDD or their family members involved in the work on conflict-free case management?
The plan is to engage with those folks, stakeholders that are diversely representative across behavioral health, including IDD. Once we are able to get to some analysis of the information that TBD was able to collect so far, and we hope that invitation to expand the membership of the Quality Improvement Council, probably a sub-work group of that council, will be issued in the fall.
Thank you for the answer. Our last question, are there any family guides to help people understand the information you just shared? The language and terminology was unfamiliar to this attendee, and they're trying to understand it more clearly to properly support their loved one.
There would be some of that absolutely through our contract work with Wayne State and my DDI for the HCBS rule implementation. I am not sure it would be around conflict-free though. Remi, are you aware of anything that we could maybe provide?
I am not aware of anything currently available, but we can take a look at that and see
Yeah.
how to best address that.
Thank you.
Right. Ladies, thank you so much for answering those questions. That takes us to the end of our questions and the end of our time.
Well, thank you so much.
Thank you so much.
Take care, everyone. Have a great rest of your week.
So thank you everybody for joining us today. And I encourage you to come back next week for our last session in the ARC Michigan Disability Policy Series. And a reminder that next week we are starting at 9:30 a.m. And we look forward to seeing you there. Thank you.
Thank you.